and welcome to today's webinar entitled PAHOWHO Caribbean COVID-19 and Respiratory Illness Surveillance and Interruption of Transmission. I want to take this moment, firstly, to convey our sincere apologies for not being able to conduct this webinar as was planned last Tuesday. After having said that, I'd also like to share with you a few housekeeping notes. Kindly ensure that your mic is muted. Place your questions in the chat, and after we have the two presenters, then we will conduct a question and answer session. Presentations will be sent to your national epidemiologist, and you can obtain them from that person. However, if you would like for us to send them to you personally, kindly write your email address in our chat. We will be recording this session and sharing that with you at a later date as well. Context to today's webinar. We're all aware that COVID-19 has spread rapidly around the world. 6,397,294 confirmed cases, 383,872 confirmed deaths, and 216 countries, areas, or territories with cases according to WHO and last updated on 3rd June 2020. These affected countries have put in place stringent public health and social measures to slow the spread of COVID-19. We have lived and experienced the limitations on domestic and international travel, stay-at-home orders, closing of schools, shops, bars, restaurants, and even religious centers, etc., among other measures. As countries and public health authorities consider the lifting of some of these measures, it is critical that robust surveillance is in place or put in place to control the spread of COVID-19 and guide ongoing implementation of control measures. The surveillance for COVID-19 is to limit the spread of disease, enable public health authorities to manage the risk of COVID-19, and thereby enable economic and social activity to resume to the extent possible. The new norm, as we all call it. Surveillance is also necessary to monitor the longer-term trends of COVID-19 transmission and the changes in the virus. At the very same time, to control the spread of COVID-19, interventions need to break the chains of human-to-human transmission, ensuring that the number of new cases generated by each confirmed case is maintained below 1. As part of a comprehensive strategy, case identification, isolation, testing and care, and contact tracing and quarantine are critical activities to reduce transmission and control the pandemic. Having provided a brief background, I now take this opportunity to formally welcome you to today's webinar. I'll take this moment then to provide a brief biographical sketch of our first presenter, Dr. Eldona Boisson. She's an epidemiologist serving the Caribbean. She works with ministries of health and other partners to ensure technical support to national and regional programs in the areas of epidemiology, surveillance, statistics, outbreak investigation, and the production and dissemination of health information. In recent years, her main areas of focus have been on the implementation of the international health regulations in the English and Dutch-speaking Caribbean countries, strengthening influenza surveillance, and the development of a Caribbean regional field epidemiology and laboratory training program. Dr. Boisson has been working with PAHO since 1998, where she still works as an advisor for disease surveillance and epidemiology. Prior to her work at PAHO, she was employed in the United Kingdom as a research fellow at the London School of Hygiene and Tropical Medicine, and previous to that, as a clinical scientist at the Public Health Laboratory Services Communicable Disease Surveillance Center, now Public Health England. At this time, she's also one of the PAHOWHO WHO staff on the Regional Incident Management System team for COVID-19 in the areas of travel and health and surveillance. I give you a warm welcome, Dr. Eldona Boisson, to make your first presentation. Please take the mic. Over.
Good morning, all. Paul, are you hearing me clearly?
Clear, Dr. Boisson. Over.
Okay, it's just started to rain where I am, so if you have trouble, difficulty hearing me, just let me know. Well, good morning to all and a warm welcome. Again, I also apologize that we had to reschedule due to some technical difficulties beyond our control, but we're very happy to be able to be here with you today. So we have two presentations, myself first, and so without further ado, I think I will begin. I'm going to focus on COVID-19 surveillance and interruption of transmission via contact tracing. Let me try to advance the slide. Just one moment, let me just try to advance. Okay, I'm just going to stop sharing for a minute and start again because it's giving trouble to advance. So just bear with me 1 second. Share contents. Okay, there we go. So, in terms of controlling the spread of COVID-19, what we really are aiming to do is to have interventions in place to break the chains of disease transmission. Really what we're aiming to do is to have an effective reproduction number, or what we call RT. That is the number of new cases that is generated by each confirmed case. And we use RT instead of R0 because now we are putting interventions in place like our contact tracing, physical distancing, hand washing, prevention and control measures. So whereas we used to speak about the RO, which was the reproductive number. Now we're looking at the effective reproductive number, that number that we actually have with those measures in place. And we would say that we have the outbreak under control if the RT is below 1. And for most of our countries in the Caribbean and territories, indeed, we've been pretty successful at that. Now, the strategy to reduce transmission and to break that chain has really 4 key components given where we are in the epidemic in the Caribbean. Right now, the outbreak in most countries and territories is pretty much under control. So what we need to do is to make sure we have 4 steps. Early identification of any new cases at this time. Isolating, testing, and of course, caring and treating those patients. Contact tracing to see if there has been any chain beginning to build. And quarantining of contacts of those cases. So from where we are, those are 4 main things we need to do. In this presentation, I'm going to focus on 2. Early identification of cases through surveillance and contact tracing to break the chain. Okay, let's see. Okay, first of all, surveillance. And these are just some of the guidelines that we have for surveillance, and I will have the full references at the end, and you would have that available to you when the presentation is shared. So what is the aim of the surveillance for COVID? First of all, let's focus on COVID before we look more broadly at ARI and SARI. The aim of COVID surveillance is to limit that spread of disease with the aim of reducing morbidity and mortality, and to facilitate our public health authorities to manage the risk of COVID-19. And very important for us, to enable economic and social activity to resume as much as possible. I think all countries and territories are hurting economically and socially. I know many countries are seeing an increase in domestic violence and depression and so forth. People are becoming wary. It has been some time since we've been in lockdown. And quite frankly, economically, we cannot afford to continue. We have to begin to open up, because without economy, we cannot fund the health sector, amongst other things, of course. So it's a fine balance between health and economic and social activity. The other aim of surveillance, of course, as you all know, is to monitor those longer-term trends of COVID-19 transmission and to monitor the changes in the virus. So testing, obviously, is important to continue. The objectives of the COVID-19 surveillance, the two main ones, to rapidly detect, isolate, test, and manage your cases, and identify and follow up your contacts. You do that by contact tracing, quarantine. Of course, there are other objectives. It would help to guide the implementation of control measures as you relax them and reinstate as need be, to detect and contain outbreaks among vulnerable populations. For example, homes for the elderly, migrant populations. I know many of our countries have a lot of Venezuelan migrants, Haitian migrants at this point in time. Also, we want to be able to evaluate the impact of the pandemic on our healthcare systems and society. That is something we need to be doing on an ongoing basis. We want to monitor the longer-term epidemiological trends and evolution of the virus and understand the co-circulation of this new virus with influenza and other respiratory viruses like RSV and so forth that have been circulating even before. And they've not disappeared either. So we need to see how are they co-circulating. Will COVID-19 virus behave like H1N1 and kind of take over as the lead virus for respiratory illness? Or will it disappear like SARS? At this point, we really don't know. So we need surveillance to monitor and understand what is going on now in the longer term, next flu season. For COVID-19 surveillance, a lot of these things you are all already doing. One is including COVID-19 as a mandatory notifiable disease for immediate reporting. We know that this is pretty much done in all the countries and territories in the Caribbean already. Your surveillance system for COVID-19, we know, is geographically comprehensive and includes all or most persons and communities at risk. We understand that many countries and territories already have the vulnerable populations included in COVID-19 surveillance. So additional to the sites and the populations that you had for respiratory illness surveillance. So as I said, surveillance for vulnerable or high-risk populations has been advanced. Now, moving forward, considering that this is not a short-term situation, you know, as this pandemic continues, I'm hearing my own lecture playing in my head, where I tell people when we have epi lectures, an outbreak is not business as usual. It doesn't stop on the weekends. It doesn't stop after hours. And now I feel like I'm living the words. But the difference here is this is one for the long haul. This is a marathon. This is not a sprint. And so we have to be able to incorporate our COVID-19 surveillance into our already existing communicable disease surveillance systems, because this has to continue for some time. So I have this graphic here. I'm not going to stay too long on it because it came from one of the guidelines that is going to be in the references at the end of the presentation and that you will have available to you. If we consider the different types of surveillance in the first column, your immediate case notification reporting, your contact tracing, sentinel virus surveillance, sentinel case surveillance, investigations of clusters, special settings, mortality. And then we look across the top row to look at the surveillance sites, you would see that half your primary care sites or your non-sentinel sites, the ones you've set up now, like your homes for the elderly, prisons, migrant areas where migrants are living, your hospitals, your non-sentinel hospitals, because not everybody had sentinel hospitals for ILI or ARI and SARI, and your sentinel sites that you already had as part of your respiratory illness surveillance. Those are key sites for all types of surveillance for COVID-19. As I said, I will not dwell on this, but I just wanted to show you the importance of the ILI surveillance. So let's move to that. COVID-19 surveillance within existing communicable disease surveillance, because I know your fever and respiratory illness surveillance is part of your overall communicable disease surveillance. Why do we have this? Well, your CD surveillance is important for identifying whatever respiratory illness is circulated, including COVID-19. Therefore, we need now to strengthen our existing syndromic surveillance systems, particularly for respiratory illness. So some countries are looking at ARI, acute respiratory infection, and SARI, severe acute respiratory infection. Some, instead of ARI, are looking at influenza-like illness, ILI, or fever and respiratory illness. And some are also looking at atypical pneumonias. Now, if we consider our existing syndromic surveillance systems for all the syndromes, but especially at this time focusing on respiratory illness surveillance, we need to be sure at this time that surveillance system has as sentinel sites the accident and emergency ward and key wards of your major hospitals. And when I say major hospitals, I'm not differentiating between private and public, because if you have a major private hospital, that should be included at this time if it is not already part of your surveillance. So this is key. Also included in your syndromic surveillance system should be your representative sentinel sites. So you all have, I know, sentinel sites as part of your syndromic surveillance systems. For some of the smaller territories, in fact, it is all your healthcare facilities, and that is fine. For some of the larger ones, you've selected sentinel sites, and that is fine as long as they are representative of your country. Of course, syndromic surveillance cannot stop with the collection of syndromes. Absolutely must be supported by testing. In this instance, for respiratory illness, testing at this point by PCR. That is the only approved gold standard test. Of course, there are many other rapid tests, rapid antigen tests, rapid antibody tests currently being developed and being investigated. And we look forward to when we can get a reliable test of that type. But for now, it's PCR. Also, some countries are trying to expand to gene expert. We know there's challenges with getting those test kits, but we anticipate that that will also be reliable. When testing, you must know your testing denominator. Obviously, you must know the denominator to be able to work out your positivity. What percent positive for COVID, for H1N1, for RSV, for whatever else is circulating, are you seeing amongst all tested? And you should be adding your COVID-19 testing to your routine influenza surveillance algorithm. You should prioritize testing your influenza negative samples for COVID-19. So what does that mean? Ideally, when you get your sample, you test for influenza. If it's negative, you test for COVID-19. And it's recommended in the guidelines to test at least 50 to 100 specimens per week. Of course, that depends on the resources that you have for testing. Now, if you actually have the resources, the human resource capacity as well, you can test influenza positive samples for COVID-19 as well. So if you have the resources, you have the testing facility, capacity, human resource, materials, you can test all your fever and respiratory or ARI or ILI samples that you collect for both influenza and for COVID-19, because you may have co-infection. That is definitely a possibility. But if resources are in any way limited, whether it's the materials or human resource, then test your influenza negative samples. And you may change as your outbreak progresses, or maybe hopefully it doesn't progress. But if it were to, and you were starting to get a lot more numbers, maybe at this point in time when your numbers are low, you may test all samples, influenza positive and negative. But then if you started to get more numbers, you may choose to then change to only influenza negative. So you need to monitor what is going on with your outbreak. Another part of surveillance you need to consider is event-based surveillance. Event-based surveillance does not replace, it complements our conventional indicator-based surveillance. So what I was speaking about before, your fever and respiratory illness surveillance. Event-based surveillance is complementary. There is a WHO guide to establish an event-based surveillance. We had, I think 2 years ago now, a Caribbean workshop, and we developed guidelines specifically for the Caribbean to establish event-based surveillance and a template for data collection and data analysis. So all of that is available as well. What is it? Just to quickly refresh your memory, this is where you're using unstructured information from both formal and informal channels. So you're not looking at your routine sources of information. You're now looking for maybe online content, radio broadcasts, print media, not necessarily just the health sector, but all sectors. So you don't just say because this was not reported through the health center or the hospital or whatever, that this is not official. No, you hear a report on the radio that there was an outbreak in a particular elderly home. Then you use that information and go and investigate. It may be false, but it may not. So you can't afford to ignore it just because it didn't come through official channels. You need to investigate. It may be as easy as making a phone call. It may be more difficult and you actually need to go there. So you need to look at and take note of those informal bits of information and act upon it. Remember, surveillance, indicator-based, event-based surveillance is for action. Of course, this requires some dedicated human resource time and clear processes to sift through the large volumes of information and to be able to communicate relevant content. In our setting, what tends to happen is the same persons at the national level, your epidemiology unit or surveillance unit, whoever's responsible for surveillance at the national level, indicator-based, tends to also be responsible for event-based surveillance. I would suggest to you, now is the time. If you do not have enough resources to have both your indicator-based surveillance and event-based surveillance running, now is the time to advocate for the resources that you need to do so. Now is the time when your decision makers have a very clear understanding of why it is necessary. I always say in my lectures as well, outbreaks are an opportunity to put in place things that you know needed to be there anyway, and that are going to serve you and the country in good stead in the future. So now is the time to ride this wave of opportunity to put in place what you need to strengthen your system the way you know it needs to be. I just want to touch quickly on surveillance amongst persons entering your country or territory at points of entry. So screening at points of entry, like thermal scanning, screening questionnaires, and I know this is happening at points of entry, and that is fine. That can definitely assist. Thermal scanning will tell you if somebody has arrived with a fever, which will trigger you to investigate more. It will not tell you, of course, if that person has COVID-19. Screening questions, if persons are honest, can give you some insight as to their risk. But if people are not honest, it is not foolproof. So it can assist. And I wouldn't say that you don't invest some resource into that, but do so recognizing that it is limited in detection capacity, and do not give yourself a false sense of security that if you have screening at points of entry, that you're safe, that you cannot have introduction of cases, because that's not the case. However, ill persons are likely to seek healthcare. especially in this time. We know our communities, we know our contexts. People don't want to die, people are scared, people are anxious. If they know they have come in from an area of risk and they come down with cases, with symptoms of COVID-19, they want to be treated. So you have an opportunity to detect cases at your healthcare facilities. And in fact, I would tell you that most, if not all, imported cases, which is what we all started our outbreaks with in the Caribbean, were detected when persons were seeking healthcare or called a hotline because they were concerned about their health rather than at points of entry. Few, if any, countries have reported that they picked up their imported case at the port of entry. They picked up their case in the country when the person was already there. Some while they were in quarantine, some not. So do not have a false sense of security that you will catch everything at point of entry. That is very limited. And remember also, at the ports of entry, I know there's a lot of discussion and some countries are moving forward with testing persons entering. Remember, this gives you only their status at point of testing. If a person is very early in their infection, you will not pick it up. You're not likely to, because they would not have built up enough virus. It only tells you at that point in time. Again, that can assist, but do not feel totally secure. I know there are some countries who've made the decision to have testing at points of entry, and I would encourage you to make sure you continue your surveillance and to look at how it influences what happens next, how it influences the progress of the pandemic. This is all new to all of us. This virus is very new, and how it's behaving is very new. And so we all need to learn from each other. And so I encourage all countries who are implementing measures, new measures that they've not done before, to please document and monitor and share with your neighbors, share with the community, so that we can all learn. In terms of analysis, it's necessary to do a routine analyses and reports and provide to all your data providers. That could be in terms of a one-pager, it could be a media conference. I know many countries are having updates daily or at least 3 times a week. But all your data providers need to be hearing what is the outcome, what is the report to your decision makers, obviously, because they need this information to make the right decisions. And ideally to your general public. And again, I know many, if not all countries are doing routine updates via the media, via their websites, and this is strongly encouraged. That helps to give you community engagement. Without that, it is pretty much impossible to implement all the measures you want to implement, including surveillance. In terms of analyses as well, you also want to do some periodic in-depth analyses, maybe not on as routine a basis, because the one I was speaking about before, that routine analysis, either daily or weekly, maybe a sort of age, sex, geographic breakdown, person, place, and time, some basic epi. But you want some periodic in-depth analysis where you're going to look at testing patterns, comorbidities, risk factors, symptomology, severity, those types of things, percentage hospitalized, how many use ventilators, that kind of thing you want to do periodically. And there are many tools available. There is GoData. I know some countries are using that, particularly useful for contact tracing, but also very nice graphics. And our next presenter will go more into that. I'm not going to say too much there. And there's a PAHOWHO WHO line listing based on the WHO 3-page case investigation form. The first third of that page is in the quarter of the slide. This form, it's not long. It has 4 parts. It's 3 pages. A lot of it is just check boxes. Some basic patient information, the clinical status of the patient, their exposure risks, the outcome. Now, if you convert this into the number of parameters that you get from this form, you end up with 87 or so parameters. Why? Because one question could generate more than one parameter. For example, does the patient have underlying conditions? It's not just yes or no. You have to tick if they have diabetes, cardiovascular disease, etc., etc. And there's about 11 or 12. Each one of those yes, no, as you tick, is a parameter. So from that one question, you end up with about 12 data parameters. So the line listing looks a lot, but it's capturing not actually huge amounts in terms of data collection, but it's structured that way to facilitate the data analysis. We also have a limited data set, 20 odd parameters that we recommend to be the minimum you collect. But I think if you can actually complete the WHO case investigation form and have all that information, it will also be very useful to you and your decision makers in terms of planning for next steps. And of course, there are other tools. We've heard from many countries who have their own data sets, databases that they are using, and that is fine. You pick the one that works best for you. In terms of reporting, I think you all know that you're required to report your national database to PAHOWHO, WHO, these two websites, the COVID website with copy to IHR. Because COVID-19 is a public health emergency of international concern, under the international health regulations, countries are required to report their cases of COVID-19. In terms of reporting the database, that is reporting on an individual level. And why we're asking to report to the two is that if you're doing that, then you are reporting to contribute to the regional surveillance and at the same time fulfilling your IHR requirement to report, so that you don't have double reporting to regional surveillance and to IHR. It's just one. Ideally, the report should be daily. However, because in the Caribbean we've been having such few cases, we have agreed that at least weekly would be sufficient for the Caribbean. And we're saying every Friday that the Caribbean reports. And most countries are doing that now, which is great. And you're reporting your database. When you have a new case or updated data on existing cases, then you should be reporting at that time. So let's say on a Tuesday, you've reported on a Friday, and then on Tuesday, you get a new case. In order to fulfill your IHR obligation, you need to report that case. So best you report that case in terms of the database, report to these two emails, COVID and IHR, and you fulfill your responsibility. If you have no change to your database in a week, on that Friday, you simply send an email to these two email addresses indicating that the country has had no new cases for this week. It is important to report, even if you have no new cases, because reporting is being used as a surveillance performance indicator, looking in terms of timeliness and completeness of reporting. So reporting to say, an email to say no cases is like saying a zero report, which I don't have to tell you is also very important. So I'm going to switch gears a little bit now to contact tracing. And again, I'm not going to spend a lot of time on this first slide here because this is the reference and it is on the end of the presentation. So contact tracing is to break the chains of transmission of an infectious disease. It is to identify, assess, and manage the people who have been exposed. For COVID-19, we're talking about identifying people who may have been exposed and following them up every day for 14 days from their last exposure. Critical elements for implementation of contact tracing, for doing contact tracing, community engagement and public support. If you do not have that support, as you well know, contact tracing becomes very difficult because you have to speak to people to find out who their contacts are. You have to carefully plan in the in your local context, considering your local communities, your cultures. You must have trained contact tracers and supervisors of your tracers. You must have logistic support for your teams, access to timely testing, and a system to collate and compile and analyze the data real time. Community engagement and public support. Why? Your individuals must be willing to comply with the daily monitoring that you're going to do, with promptly reporting signs and symptoms to you, because you may not be able to see everybody if they're at home. You may be calling. They must be complying with going into quarantine for at least 14 days or isolation if they become symptomatic. You also have to engage to be able to identify challenges. Language. Those of you with Haitian communities, you have to be able to engage in their language so that they can understand. To determine if there's issues of stigma rising, you know, if someone's identified as a contact, are they stigmatized, and is that going to prevent them? Marginalization. Assuring them of access of food and medical care for their illnesses if they're in quarantine, for example. You can use this opportunity of engagement to address the benefits of doing this. The common good, assuring them of privacy and confidentiality, letting them know how information will be used, and to assure them that persons who may be concerned that this is not going to be linked to immigration or security or other things they're concerned about. And you have to think especially about how you're handling contact tracing for your vulnerable groups, your high-risk groups like minority groups, homeless people, for example. How do you find them? Migrant workers, refugees, and so forth. Quickly, I won't spend time because this is in the guidelines. What is a contact for COVID-19? Anyone with any of the exposures below, 2 days before and up to 14 days after your case has started to be ill. Or if the case is asymptomatic, from the date the case was sampled. So anyone with any of these exposures, being within a meter for more than 15 meters of the case, having direct physical contact with the case, providing direct care without proper PPE, persons in the same household, those in long-term facilities or hospitals who are sharing a room, a bathroom, a meal, persons who have visited within the time, public transport, persons who are sitting within 2 rows of a COVID patient for more than 15 minutes. And we're familiar with that. For example, with TB, if you're in an aeroplane and we identify a TB case, you want to make contact with the persons 2 rows before, 2 rows behind, and on either side. And of course, any staff who was in direct contact with the case. Where are you looking? You're looking in households, you're looking out in the community, in closed settings, for example, your long-term facilities, your prisons, your shelters, your hostels, healthcare facilities, public transport, places of worship when they open. I know most are closed. And you have to develop a list of persons who were in contact with each and every case. And each person on the list has to be contacted to determine if they meet the definition and therefore are they a contact. So you get your list of persons who are in contact, who you believe were in contact, and then you speak to them to see, do they meet the definition? Then you determine whether you're monitoring. How do you identify? Well, direct interview with the case or their caregiver. This could be done face-to-face or virtually. You can, in a long-term facility, interview the coordinator or the head. In a long-term facility, you can look at the list of residents, visitors, they normally have a log, staff, if it's a school, students, patients, and so on, who are in close proximity or sharing facilities. So if you have a long-term facility and somebody was in their room, and they didn't leave, you're looking at those who were in the room. If they left and they were only in contact with a limited number of persons, then those. If you have a social event, you're looking at the guest list. In public transport, where possible, you're reviewing the seating plan, like in a plane, maybe, flight manifest. More difficult, obviously, in a taxi. And sometimes, for example, in taxis, and sometimes in some social events, you can't trace. And so therefore, you have to use media releases to say, were you on this flight? Were you in this mall during such and such period on this day? Please contact. So, you know, if you do identify contact, meets the case definition, you quarantine them. If they're well for 14 days, and you monitor for symptoms and move to isolation if they become ill, and you test at the end, if possible, and if they're negative, they can be released. If they become ill, you isolate, you treat, and you need 2 negative tests at least 24 hours apart when symptoms cease. The type of quarantine depends on what you have available to you in your country. Daily monitoring for signs and symptoms can be by direct monitoring face-to-face or calling up by phone or virtually, or self-monitoring by the contact and asking them to report symptomatic or not on a daily basis. If you do that, for those persons who do not call in, you still need to follow up because you must have daily contact. And you need to collect some key minimum information. Here, I'm not going to go into this quickly because I know we are over time, I'm sorry. The key types of information, there's some you put in once. The identification of the contact, the demographic information, the type of contact, and actions taken if they're symptomatic. Daily follow-up on signs and symptoms, and you also, if they were to become lost to follow-up or absent, you need to also capture that information. Contact tracers must have an appropriate level of literacy, good, strong communication skills, must have language literacy, proficiency of who they're speaking to, because they have to make themselves understood, understand the context, the culture. So it's good if the contact tracers are recruited from their own or similar communities. In many of our countries, many parts of the country are homogeneous, and so you can use contact tracers throughout the country. But you may have some migrant populations, for example, and it would be great to have contact tracers from within their communities. Preferably not medical staff. Use your medical staff for care and treatment. And contact tracers should have training on the basics of COVID-19 transmission, prevention control measures, how to do the monitoring of signs and symptoms, ethics of surveillance, and quarantine. They should maintain a safe distance of more than 1 meter when interacting with the contacts or suspected cases, and preferably conduct their interviews in well-ventilated areas or outside. And you must have supervisors assigned to their teams so they can provide the technical and logistics support, quality monitoring, solve any problems that may come up. Some additional considerations, and below I have some graphics from GoData, which you will see a lot more of in the next presentation. Equipment and logistics. You must think about what kinds of things you may need, administrative, material, and other logistics. Do they need ID? Do they need transport? Do they need a tablet or paper? Do they need a mobile phone? Do they need credit on their phone? Appropriate PPE, masks, sanitizers, gloves. Electronic tools and IT, not essential, but it definitely makes it more efficient and facilitates the analysis and implementation. Data protection, obviously very important. The ethics of your public health information, data protection, data privacy has to be considered and respected at all levels of contact tracing activities, including your training activities and in implementation. Just for the EPIs, you need to also, in analyzing, look at your daily monitoring indicators. Again, these are in the references. So I'm going to move briskly to the last and shortest part, personal protective equipment when collecting data in the context of COVID. And this is whether you're collecting surveillance data or whether you are collecting data from contacts or suspected cases. For us to know this, we need to be able to assess risk. So I quickly want to go through, how is COVID spread? It's spread through small droplets from the nose or mouth when a person with COVID-19 coughs, sneezes, or exhales. The droplets are relatively heavy and fall on the ground or nearby surfaces or objects. It does not carry in the breath that you breathe. It is your respiratory secretions, the saliva, the coughing up or sneezing out. It is the liquid, not just the air that you breathe. So if it's saliva, unless somebody is, as we used to say in school, spitting boulders, which is not how most people talk, then you're not going to have saliva coming out. So how do people get it? You breathe in droplets from a person with COVID-19 who coughs out or exhales the droplets. And this is why we say it's important to stay more about 1 meter away from a person who is ill. We say at least 1 meter. I know very well in many countries they are saying stay 2 meters away. That's fine, at least 1 meter, 1 meter or more. The other way is if you touch a contaminated surface or object, and then you touch your eyes, nose, or mouth, because the virus enters the respiratory secretion. If it's on your hands, it's on a cut, it does not make you ill. It has to enter the saliva or the secretions of the nose or the eyes to infect you. So if even you were to touch a contaminated object and you did not touch your eyes, nose, or mouth, then you cannot infect yourself. You wash your hands before, and that kills the virus. It has a weak envelope that is broken down by soap and water or alcohol, alcohol-based sanitizer. Now, we do know there's some reports that COVID-19 cases with no symptoms can transmit the virus, but it's not yet known how this happens, how often it happens. Most are by transmission of the virus by symptomatic cases. Of course, we continue to assess and look for additional ways it can be spread. So how do you protect? Frequently clean your hands with soap and water, alcohol-based rub, so that if you do have virus on your hands, you kill it before you touch your face. Maintain a distance of at least 1 meter from people coughing or sneezing. Don't touch your eyes, nose, or mouth. If you're ill, cover your cough or sneeze with a tissue and throw it away, or bend of your elbow so that you are not having the droplets projecting out. Stay home if you're well. Stay away from people. If you have a fever, cough, or difficulty breathing, seek medical attention as soon as possible and stay informed on the latest developments of COVID from reliable sources. So, the different types of personal protective equipment. Medical masks are useful for persons who have symptoms of COVID-19, coughing, sneezing, and persons caring for those within 1 meter of the ill person. It's very difficult to care for someone further than 1 meter away. Respirators like N95 should only be used by medical personnel doing aerosol generating procedures, your intubations, ventilators, bronchoscopies, and so forth, not for somebody just giving care. Why? Because aerosol generating procedures project it further away. I know many countries are recommending the use of masks, and of course, even if you're not ill and not caring for somebody, you have to be guided by your local authorities. Gloves, what is the function of gloves? Useful to prevent exposure by direct contact with body fluid from an infected person. Does not replace hand hygiene. You must wash hands before and after taking them off. Your goggles and face shields are used to protect your eyes, nose, and mouth from risk of contact with secretion, so it's a barrier. And gowns or aprons are used in addition to gloves if there's a risk of fluid or blood splashing onto the body. So knowing what the different pieces are used for, let's look at what you are doing when collecting data. If you're collecting data at a distance of greater than 1 meter away from your cases, all you need is hand hygiene. Make sure you wash your hands before and after the interaction, because the person is far enough away that they are not going to be in the distance in which the droplets fall. If you know, as we discussed, the other pieces of equipment, they are not needed. Now, if for some reason you have to be within 1 meter, you should also use a medical mask and gloves. If for some reason, and for most persons, I would think collecting data or contact tracing, this will not be the case, But if for some reason you're entering an isolation area of COVID-19 cases and giving direct assistance to that person, then you also should use your gown and goggles for eye protection. But for most persons, I think it will be one of the first two instances. These are references you will get when the slides are shared, and all the data I've spoken about and more are contained in here. And at this point, I thank you for attention, and I really apologize very much for going over time. I will hand back over to Paul now, Dr. Edwards, but I think we can extend the Q&A session if need be. Over.
Thank you very much, Dr. Bosson, for that great, informative, and comprehensive presentation. In all honesty, it took me back, and it was deja vu as it related to the early 2000s at the epidemiologists and lab directors meeting. Thank you very, very much. Gentle reminder to the participants, kindly write in the chat your question and answer your questions, because we will have a question and answer session after the second presenter. So I take this opportunity to now introduce our second presenter. He is Dr. Angel Rodriguez. He has a master's in public health. He's a specialist in preventative medicine and public health. He has been collaborating with PAHOWHO since 2009 as a technical officer at the Alert and Response Team, and currently as technical officer in surveillance of influenza and other respective viruses, including SARS-CoV-2. His experience includes working with the organization in the response to the 2009 influenza pandemic, the Zika emergency in 2016, and ongoing COVID-19 pandemic. Thank you very, very much, Dr. Rodriguez, and you can take the mic. Over.
Thank you, Paul and Eldona, and good morning, all the colleagues in the Caribbean. Thank you so much for the previous presentation, Eldona. Very comprehensive, informative, and will support and facilitate these presentations. Okay, so I hope that you are listening me well. Okay, so and seeing my screen. So please confirm just with the thumbs up, Paul. Yeah.
Yes, we are. We're hearing you. Your screen. Over.
Thank you. Okay, so I have 10 minutes for this presentation, and then after that we can have a round for comments and discussions. I named this information for action. Basically, is the result of the surveillance part of the surveillance process that Eldona explained pretty well. And now we're about the data analysis. This is the agenda for the presentation. The objectives mainly not for the presentation, is more for the data analysis. The data sources for COVID that we are using and the analysis that we are conducting, and lastly, the key message, okay? So please note that the intent of this presentation is not to describe the epidemiological situation in the Caribbean. We are going to see a lot of analysis, a lot of description. Of course, I can describe some, and if you have question about the graphs of the analysis, of course, we can talk about this. The main important is like the use, so all the products, all the information that is analyzed based on your data, the data that your public health clinicians and other workers are conducted at this moment at the local, regional, national level, and provide to the organization, to the region, and to the world to monitoring this pandemic, and also to do risk assessments, analyze prevention and control actions. In each slide is the reference or the link to this information. All the information that we are going to put here is public, and then you have the reference and the resources for that in each presentation. And then with that introduction and description of the structure of the presentation, let me start with this. So this is basically 5 objectives for the surveillance/data analysis. That is also a reminder of the previous presentation. So basically, the importance of rapidly detect. We as organization, we are strongly recommend that the countries start continue doing the case-based surveillance, basically to conduct the rapid detection, isolation, testing, contact tracing, quarantine of this to stop the chain transmission, but also to detect exportations, okay, prevent exportation, and also detect early importations when the borders are open, okay. Monitor, of course, the trends of disease is part of this combined strategy for surveillance, not only containment, but also the trends of the disease, with the diseases in the community. Provide, of course, biologic, clinical, and epidemiological information. Risk assessment, we are going to touch base about the risk assessment. That's the main important, one of the key points of these presentations. Provide the information to the key leaders, the key decision makers to take actions, like open borders, that open the facilities, no, things like that, the schools, mass gatherings, things like that. Okay, and of course, but more important, the international coordination and information about the situation in your country and in the Caribbean sub-region specifically. Okay, so as an organization, we are part of the incident management team and response in the region. And we are using these three main data sources. One is all the daily counts of the COVID cases and deaths that you are publishing at your Ministry of Health bulletins in the Caribbean or other regions in the Americas. Also, the situation reports that I providing to the organization, we are extracting using that information and creating a database. The other is the line list of COVID cases, confirmed and probable, that you are sharing, and we thank you for that, and also encouraged to continue doing, because it's part of the rapid detection and this strategy. And just to mention that we have in the 80% of the cases recorded in the Americas, we have the nominal information. So we are the region with the more data as nominal information, and of course this is the result of the analysis and that you're going to see next. We are working together with, is not only case-based surveillance, is not only event-based surveillance, it's also syndromic surveillance. And we have here the other data sources, is the SARI ILI surveillance / ARI surveillance that you are conducting, and you are integrating the SARS-CoV-2 surveillance into the influenza platforms. Okay, right now in the Americas, we have 20 of 35 member states, including the SARS-CoV-2 into the influenza surveillance, almost 60%. And we encourage the countries that are not doing yet to include, because that's the way that you can also monitor the transmissibility of the disease. Okay, so I took this time to really explain this, and now I'm going to move more quickly with the data. Okay, but I think it was important to have all the background of all this information. So right now we are going to build at global level. Right now you see this is a product that at global level WHO is creating the situation reports. Here, as mentioned, are all the links for these situation reports. These include the information of the whole Americas about cases and deaths. Is more daily and is published in the WHO website, but also include the countries, the reporting country, territorial area by the country / territory, the cases, the deaths, total new deaths, and the transmission classification that is based on your analysis. Okay, dates since last report case, pretty important for risk assessment. So you have available this information on this platform, and it's a easy way to see how is the situation in your countries or territories. Okay. This is part also WHO global level, part of the WHO COVID dashboard, that you see the map of the Caribbean sub-region with the cases, confirmed deaths. You have also a dashboard, interactive dashboard, here to see the cumulative cases, cumulative deaths, also the percentage per 1,000 population, things like that you can see the trend here, including your country, using these filters. Again, the situation for the Americas and the epicore by sub-regions that you can see right now, how the Americas right now is the epicenter of the epidemic after the other regions are going down with the situation. Again, now the link here, okay? This is the global level. Now we are going to talk about mainly PAHO and all the information that we are conducting that is public available and the analysis that we're doing. This is the map of the dashboard that is in our website for PAHO. COVID is here. You see the situation about the cases in the map and also the color and the dots about the size of the cases recorded by subnational level, cumulative cases, that's the cases that are recovered, and of course the EpiCorp that you are seeing at this moment. This is interactive and is one of the information. Okay, of course, you need to have a lot of information to conduct a very good risk assessment analysis, clinical epidemiology. We also at PAHO have the situation reports here right now. This is the COVID situation reports that are published in our website, okay, with all the clinical, epidemiological, virological situation, but also about the response and the actions conducted and the collaboration that we are doing as organization. Total numbers by sub-regions, okay, and also the table with the cases with the largest number of cases recorded reported to the organization in the last days. Okay, here you see right now US, Brazil, Peru, Chile, Canada, and Mexico with the highest numbers are mainly at the peak of the situation of COVID at this moment. Okay, so here is available. The situation reports include analysis, including the EpiCourse. Here is by country. This is Americas only, all the countries, EpiCourse by countries in the whole Americas, and of course in blue is the US. Okay, and you can see here below the deaths. Okay, this is new COVID cases by all country or slash territory, and this is the new deaths and country and territory information also available for you in the in this situation report. Right now, also PAHO develop a hub of information because we noticed that we have a lot of information to present, analyze, and also be available to the public, but also to you, to your public professional and the key elements. So we are using a lot of tools to present this information. We are using RGs, we are using Tableau, Power BI, a lot of tools to analyze the R as a statistical analysis. We have a lot of tools, a lot of statistical package to do this analysis because those analyses are different and not all the programs are really strong to present information. So we develop a hub to put information based on different platforms and aggregate all this information. This is a summary of the Caribbean sub-regional part of this hub. You see 34 countries or territories reporting this number of cases, this number of deaths, the EpiCourse by the sub-region, and here the cases, the territories, countries with the highest cumulative incidence rate by country or territory, and also here the information in the Caribbean. Case and rates, dynamic map as well. This is in this hub that you have this information available, okay? Specifically for the Caribbean, also specific maps for the sub-region about the situation of cases at this moment. And apologize, this data is as of 1 June because we expect to present this last Tuesday, but the information I think is still valid to see and represent the situation in the Caribbean. This the number of cases recorded as of 1st June, and also the deaths, including for a case fatality rate of 3% overall in the sub-region. This is the low in the sub-region in the Americas actually. So this is other information that is available for you. Also another product that we are developing when other new information is available, new guidelines are available, or when we adjust the risk assessment for the COVID situation in the region, we elaborate the EPI update. Right now, the first one is the EPI alerts of COVID. Now, as the EPI alert was published, now is the EPI updates, but also include the situation by sub-region, the actions, the risk assessment, and also provide updated guidelines and recommendations. This is the last one published 22 of May with updated guidelines for surveillance, lab, and other. And here is the situation of the countries of the Caribbean at that time, like reporting only sporadic cases or cluster of cases of COVID at this moment. And here you have the cumulative cases per 100,000 population in the Caribbean, and see how the court, you know, the situation that you don't record here, in this case, Falkland Islands, more cases are recorded, new cases. So it's an indicator that the epidemic is stabilized of the change transmission stop, you know, and we have all of this information also by the other countries or territories. Now, again, I'm going to return to the hub. I have 5 more minutes, and then here is the Caribbean and Atlantic Ocean Island updated. Okay, here you have the numbers, the countries reporting the cases, the deaths, case fatality rate, and the situations. Also, you have available all these variables here to see and obtain this information for analysis. This is the link, the public link that we have all this information. Is including also this table that we are publishing also daily about the situation of cases that's recovered, but also the transmission type that the countries or territories are reporting, experiencing, with the total by the sub-region in here, another product available for you. This is also part of the hub and part of the specific dashboard that we are creating with the line list of the cases, deaths by sub-region, but also by country. And you can see here the description by age group, by gender as well of the cases, and you see how the younger are more affected in the Caribbean at this moment, with really not much difference between genders. And you can see here information, important information for the Caribbean, and also when you compare with the deaths, this is the deaths information also by age group. You see how it's different, the situation about males, you know, mainly, and in the older age groups, with the more case fatality rates of deaths recorded in this. Okay, so it's another information that you can trend monitor by sub-region, but also by country. Okay. Severity also based on line lists. This is all the information of the countries that are reporting line lists in the Caribbean. So as you see, hospitalized, only 32% of the patients has been hospitalized in the Caribbean. In data previously, we say like only 20% were hospitalized, 80%, you know, mild, not severe. But now you see in the Caribbean that you have 32% hospitalized. Different when you contrast the information with ICU admission, only 1% were admitted to ICU, and only 3% receive mechanical ventilation. Okay, so it's also information that you have these indicators for severity. Specifically, we are showing here the dashboard of the country profile. We're showing Jamaica information at this moment about the epic curves by date of report, but also by date of symptoms to monitor the movement, the trend of the epidemic. Again, information about hospitalization, ICU admissions, ventilations, but mainly pretty important, and this is related with the actions conducted to see the timeless event, you know, like onset of symptoms and lab diagnosis, and the time, onset of symptoms and isolation, lab and report, onset and hospitalization. So these indicators are pretty important to really stop the transmission, because if you detect a case and isolate between less than 3 days, you can really stop the transmission. Okay, or for this part, so you can monitor here your performance for actions, not only the situation, as you can see. Okay. The integration about the SARI ILI surveillance, the COVID into the SARI ILI surveillance is, as I mentioned, 20 countries integrated in the Americas, and all this information by country, by regions are included in the weekly influenza report that is published here every week. And right now, as you see, we include the SARS-CoV-2 information with the percentage also detections by subregions. Okay. And this is the information about the Caribbean, and also for the cumulative numbers. There is a lot of other indicators by country, by sub-region about this information in the weekly report. I'm not going to discuss about, open for discussion later. Here you see also the positivity by influenza in red, the circulation by RSV in blue, and here the positivity for SARS-CoV-2 2/COVID, now with an increasing trend in recent weeks in the Caribbean after the peak recorded here, and now we're seeing at least 2 or 3 countries with these increased detections. Also, this information is by other subregions, and now in the Caribbean as well, the detections and the percent of positivity in comparison with other respiratory virus as well. This information is also published as a dashboard, but also in the weekly influenza report. All this information is for the Sentinel surveillance. I'm about to end the presentation at this moment. Also, this is in the hub, information about the doubling of cases and deaths by countries, territories, and you can select here. And this indicator is mainly when you are doubling cases in less, in 4 days or less, that your epidemic is very really active. And other countries that are duplicating or doubling cases after 7-8 days, you see how the control is working or stabilized. Okay, so it's another indicators that you can see to see the transmission at the moment of the epidemic. This is one of the last. This is the effective reproductive number that Eldona explained. And it's also by country, so you can filter here by your country. We are seeing here Haiti about this detection, but also how the RT is moving right now, and this is above 1.5. So we learned that less than 1 is the goal. So you can monitor here right now a strong indicator for transmissibility here. Okay, and as I mentioned, this is also in the hub and it's available. You can see the information by country filter. Other information, this is also about the growth and trend of the cases. We are seeing here the Dutch territories, and also highlighting the date or week date that the public health and social measures were implemented, and how the epidemic moved and stabilized here. Okay, the information is available with the data that you are providing, and this is the last information about the analysis that we are conducting. This is the genomic surveillance that also we are part. Is mainly countries from Latin America and North America providing this genomic surveillance. A lot of countries in the Caribbean also have the capacity to do this and share this information. Here is the information for North America and South America. When you see that we are in the sub-GH, GE subclade for the sequence genome for this, and this is pretty important for the vaccine of the SARS-CoV-2 virus. Okay, this is my last one. I'm not going to take more time here. Just the key message here is like these indicators, transmissibility, severity, and impact are needed to monitor daily, weekly, okay, for adjusting your public health and social measures. And your risk assessment, as I mentioned, need to be with these factors, epifactors, your healthcare capacities, your public health capacities, and also reiterating the recommendation to integrate and use your existing respiratory disease surveillance systems to include the SARS-CoV-2 into them and to monitor the syndromic data, but very, very important to maintain the influenza surveillance. Influenza circulate the whole year, and some periods with more increased periods of transmissibility, but remind that the threat of any novel influenza virus to cause a pandemic still is there, okay? Or also detect any virus that is not circulated in humans, like avian influenza or other viruses that also can put a potential pandemic that you need to be also conduct the surveillance for that. And this is very important. Eldona talk about also the lab analysis in parallel SARS-CoV-2 or influenza, and depends of the situation of the epidemic. You can put SARS-CoV first and then influenza, or first influenza and then SARS-CoV. Okay, and this is the end of the presentation. Thank you very much, and open for comments and questions.
Dear Angel, thank you very much. It is always gratifying to know that when countries do send data, and sometimes it can be challenging at the level of country to acquire this data and send it on a timely basis, to be able to see the utilization of all the efforts exerted at the level of the country. So thank you very, very much, Angel, for that. So we'll move quickly now into the question and answer session. I see that we do have 3 questions here. The first one is, we have received several appeals from the public requesting the use of face shields instead of face masks. What is PAHO's guidance on this? The use of face shields instead of face masks. Over.
Paul, if you like, I can start with that. So if we go back to what is the reason that we use these pieces of equipment. Face masks and face shields are really to block droplets from coming out, and if you're a healthcare worker, getting in to your nose and mouth for masks and nose, eyes, and mouth for face shields. Therefore, if you are using a face shield, sometimes, depending on what you are doing, and always look at your level of risk. Sometimes you use a mask and then a shield. You use the shield as opposed to goggles if you want to also protect the eyes. And for healthcare workers who are going to have to get within a meter of people who they're caring for, sick persons, they will want to protect the eyes, the nose, and the mouth. So they will want to use a mask as well as goggles or a shield. In terms of instead of face masks, I would say if you're dealing with a sick person within a meter, you need to protect both the eyes and the mouth and the nose. If it is that you are also not able to tolerate a mask, you are maybe asthmatic or something and you cannot tolerate a mask, then you may need to use a shield instead of a mask rather than in addition to a mask. So I don't know if anybody would like to add, Paul or Angel.
Aldona, that was a pretty good response. I think very concise, even utilizing the examples, very appropriate. So I think what we could do now, if Angel doesn't have, Angel, are you okay?
Yes, nothing to add to that response. I saw that I have 2 questions.
Yes. I think the second one is for you, Angel. You did allude to it in one of your last slides. What is the RT in the Caribbean at this time?
Thank you. No, well, the RT need to be calculated by country or territory because you can aggregate it by sub-region. And in case, I see that Dr. Ahmed is asking this question, in case of Dominica, right now the RT is 1, okay, in case of, for Dominica. And this is based on the information, you need you need information to calculate this, you know, the RT about with the cases reported and by weekly. So you need this data to do it, but you need to do it by country, not by sub-region. Over.
Thank you very much, Angel. Gentle reminder to place your questions on the chat. There is a third question. Is there any way PAHO can assist in having Caribbean countries in the IHME COVID projection?
I just ask IHME, what is that acronym?
So I'll ask Dr. Ahmed.
Dr. Ahmed, could you clarify IHME? In the meanwhile, I'll start in terms of projections generally. There is a lot of focus. Okay, there's a lot of focus of late on projections and modeling. Institute for Health Metrics and Evaluation. Okay, sure. There's a lot of focus. I think we have some background. I'm not sure where it's coming from. Is it your mic, Paul? Okay, doesn't like 2 of us on at the same time, I guess. So yes, in terms of projections and modeling, there's been a lot of focus on that. The challenge for the Caribbean is this. Our numbers are very small, which is a good thing. Our numbers of cases and numbers of deaths are very small. Because of that, in using any modeling and projection, remember you have to feed the model to be able to get the outcome. It means that your numbers are very small, very few, and because this situation is new, we have a lot of assumptions. When you combine small numbers with many assumptions, the reliability of what you get out of the model and the projection is very unstable. So for example, if we were to try to do some kind of projection, let us say you have a population of 100,000 people, and you put in things and you have a lot of assumptions, you end up with wide confidence intervals because you have very small numbers, a lot of assumptions. And if you have a population of 100,000, and what comes out in your projection is, well, we can project that in the next month that you're likely to have cases between 1,000 and 90,000 people, that's not helpful. That's really not saying anything to you because those confidence intervals are too wide. So because of our small population, small number of cases, small number of deaths, any modeling that we do is not very stable, unfortunately. So we are trying to work, and I think Angel may know more, with the Health Metrics and Evaluation Institute to see what could be done with small populations, but it is always a challenge with any modeling, HIV estimates, anything, when you have small populations and small numbers of cases and many, many assumptions. So at this point in time, while we continue to try with the modeling and the projections, the most important thing, given where the Caribbean is now, is to try to have that RT remain low or get lower by the strategy I alluded to in the beginning. Identify cases, identify contacts, isolate cases, quarantine and monitor contacts, and keep your public health measures and social measures in place and try and keep that RT low. So it may not be the answer that you're looking for, but it's just a difficult situation because of the small size. I don't know if Angel would like to add anything to that. Over.
Thank you, Lana. No, I think you explained pretty well. But also, we just to confirm that yes, here as the incident management team, we are working with these models, not specifically. Well, some groups are working with the Institute for Health Metrics, but others we are working with another groups in Europe and here also in the US. And of course, we can, as Donna said, we can, if countries are interested, we can explore some for small countries, territories, but the data is important. You know, you need to feed the model with data and to have a very good take decisions with that. Over.
Thank you very much, guys. So we have another question that just popped up. It says, we have tested asymptomatic persons positive. How infectious are these persons if 2 days after being tested positive, they are still asymptomatic?
Okay, so what we've been seeing, there have been reported cases of transmission from asymptomatic persons. However, what we're not completely clear of yet, because this is still a relatively new situation, is how often this actually occurs. The data so far suggest that its spread is more from symptomatic than asymptomatic persons. Also remember the two mechanisms for transmission: droplet, which again, it's when you're symptomatic more than anything, you have droplets, and contact. So for your asymptomatic, there's probably a higher risk of contact transmission. Either you touch a contaminated surface they touch, and then you touch eyes, nose, or mouth, or direct contact, sharing of eating utensils, and those types of things. So at this time, yes, we recognize there is a role in transmission, but how frequently it occurs in asymptomatics is unclear, but it seems like the evidence suggests it's more from symptomatic than asymptomatic, that you have a higher risk. Over.
Thank you very much, Eldon. I'll make the last call for the last question. It's a burning one. Here's your opportunity. So, and Dr. Angel, I think we've had great presentations. It has been very informative. Are there any parting shots or last comments before we close this very informative session? Donna, would you like? Yes. They're asking, will the presentations be shared? Definitely. Like I said at the very beginning, we will share with your national epidemiologist, make contact with that individual. If it is burning for you, kindly share your email address here and we will certainly send it to you. We still do contact tracing from Dr. Rajesh Ori.
I think maybe that's a follow-on question about you still do the contact tracing if you have an asymptomatic person test positive. Absolutely. If once it's a positive case, symptomatic or asymptomatic, you still need to do the contact tracing because you don't know. They may have had transmission. You don't know what the risks were. So you still do the contact tracing interview and determine if indeed you have true contacts. I see another question, Paul. Is there a role for, let me just finish contact tracing from when? From, you need to continue your contact tracing up to 14 days after that asymptomatic person was sampled, because of course you can't say from when they had symptoms. So 14 days from when they were sampled. The role for immunity passports. That's a very tricky one because, okay, so we have some more. So let me look at the questions as they come. The role for immunity passports. The mic is open, Paul. Yeah. So that is a tricky one because at this point in time, we do not yet know how long persons get immunity for after they have been infected. So that if you have any, first of all, to know that you have had it, we don't have any reliable antibody test yet to show that you have antibodies circulating. We have a lot of false positives and false negatives with the antibody test. So we don't have a reliable test to show that you do have antibodies. The other thing is, after somebody tests, so we have a reliable test to show that you had the virus, the PCR. So after that now, how long are you immune? We don't know this. So for those two reasons, at this point in time, WHO is not recommending immunity passports because there's no guarantee that the test that you're doing to show immunity is good, because we have no effective test. And secondly, how long will that immunity last? So if you test today and you were to find out that you have immunity, how long can you say that you will be immune for? Will you still be immune next week, next month? We don't know. The virus is still too new. And so if even we were to get a test, it will probably, an antibody test, be more useful for doing things like seroprevalence tests amongst populations, as opposed to testing to say, okay, this person is immune. Because you will have to keep repeating those tests over and over because we just don't know yet. So it's going to be some time before we can have some sense of how long immunity is. We know, for example, influenza is about a year or so, which is why we have our annual vaccines, and we know that we may have slight changes within that time. But COVID-19 is too new. We just don't know yet. Paul, I see another question. Do you want me to take the questions that have come up, or do you want to stop in between? How do you want to deal with that?
If you are seeing them, go right ahead, because then we'll save a little bit of time. Go ahead.
Okay. So I see another one saying, how long should cases remain in isolation? We've had cases remain positive up to 7 weeks after their first positive PCR. Right. So what is recommended is after you've had a case, so somebody who you have tested positive, after they've done their 14 days incubation, what we've been hearing from the labs is you still tend to get some positive tests up to about 5 days or so after that. essentially what you want, and so what they're saying in terms of conserving tests, better to test after additional 5 days after the 14th. When you test after that, you want to have 2 negative tests. Now, I see you saying you've had some tests up to 7 weeks after their first positive. The other thing that we have been seeing is that persons may test and have a positive test, but they are testing showing fragments of the virus, but they're not actually infectious. So this is a very tricky one as well, because we're not sure when you stop seeing those fragments of the test. So how long to keep them in isolation? After 7 weeks, that is a bit much.
Donna, can I jump in? Apologize.
Absolutely.
Yeah, just update on this, because I put in the chat right now that the clinical management of COVID guidelines were updated 27th of May, sorry, and including these new guidelines for discharge. So basically, you don't need the 2 negatives now after 14 days. Okay. Right now, the situation is a patient hospitalized. Okay, after 10 days of onset, 10 days after the onset, need to fulfill at least 3 days, okay, with no symptoms, no fever, no respiratory symptoms, okay? With that, you can discharge the case. The other is about the asymptomatic case. The asymptomatic case, you can discharge the case after 10 days of positive test. Okay. After positive test, 10 days. The other is about the release of contacts for quarantine. That is still 14 days. Okay, 14 days release after quarantine the contacts that do not show any symptoms. The contacts which present with symptoms, of course, the recommendation is to test. Okay, and also it's clear here that we are not recommending testing for asymptomatic cases. Okay, also is stipulated here, and also is in the guidelines of data is like the antibodies, SARS-CoV-2 antibodies are not using recommended for acute infection. Okay, as you previously mentioned about this. Okay, so that's just to put the new recommendations about these guidelines, and it's available in the link provided. Over.
Thank you very much, Angel. So I think that answers the questions very directly. I see that says there's some videos going around in which it's stated that if you stay long in a room with coronavirus droplets, the people can be infected by the smaller molecules that keep hanging in the air. So we don't have any evidence of molecules hanging in the air. If you have an aerosol generating procedure, your suctions and bronchoscopies and so forth, the droplets can go further because they are mechanically being propelled. If not, the droplets are relatively heavy and they fall within a meter or so from the person who has expelled them. So we don't have any evidence. There's a lot of videos, there's a lot of fake news. There's no evidence of droplets sort of hanging about in the air. Perspectives on movements of some EU countries to reopen their borders with no mandatory quarantine. Okay, so that's a question. So remember that some of the EU countries are in a very different position to the Caribbean. Some of the EU countries have community spread, many of them. And so their decision-making will be from a very different context to the Caribbean. They already have many cases. And so, for example, I would hazard a guess to say that a person coming from most of the Caribbean countries going to some of the EU countries are probably more at risk themselves of getting COVID from the persons in those EU countries than the EU persons are getting COVID from the persons who came from the Caribbean. So, I mean, remember, if you have community spread, the issue of quarantine is now being thought of in a different context. My understanding, there's many of them are recommending home quarantine because there's no way that they can possibly do mandatory state quarantine for the vast number of persons that they already have, let alone the persons that are coming in. So again, the perspective, it really depends on the country context, where they are in the epidemic, what resources they have, and their EU situation is completely different to what it is in the Caribbean. Don't know if Paul or Angel would like to add. Over.
Yeah, great with that response.
No, nothing to add. Thank you, Donna.
Okay, Donna, we've gone over a little bit over time. I'm not seeing any other questions here. So I'd like to say thank you very much to the participants. And if you have any last comments to make, and Angel, we'll give you the mic to close. Thanks.
No, just to thank everybody for their time this morning and to say that I hope it has been a useful session. And certainly if there are further questions, please feel free, if they come to mind later on, to channel through your PWR office. They can come back to the same team who's hosted this session. I know everybody's very busy, and I thank you so much for your time this morning. Over.
Angel, any last comment? Over.
No, just thank you and congratulate for all the hard work that you are conducting in your country's territory. Thank you so much. And we are here from support you if anything is needed, and we can, of course, doing it. Over, and thank you again.
There's one last question for still on, and I'm certain you'd be able to take it. Where is the best place to have the person swabbed?
The best place, it depends on where the person is. For example, if you have an elderly person, you will probably have to do the swabbing right in the room. So I'm not quite clear what they mean by that. It depends on the context where that person is. You would want to do the swabbing away from other persons in an area where the person who is doing the swabbing has the necessary PPE in order to do so. But a part of it will depend on the context of the person where they are, generally away from other persons who do not have the necessary PPE. I'm not sure if that actually responds to the question.
Donna, thank you very much. Angel, thank you very much for all those who participated in this webinar. Remember, as Eldana said, if there are more questions, you can guide it to us. Have a great day. Over and out. Bye-bye.
Bye-bye. Thank you.
Thank you. Goodbye.